Raise your hand if you've heard the term real world data or real world evidence. Has anyone heard that? Does anyone understand what it means? Okay. Well, we'll talk a little bit about that. We have a small group, so if anyone has a burning question, please interrupt me. Um, but this is the way I frame the talk. So, talking about what is real world evidence, I think not a lot of us understood what that is, and I didn't, frankly, until I got into the field. Why is it important? And then I'm going to give you some examples in kidney cancer. So specifically, there's something called the IMD risk classification system you might have heard about, and then some of our initiatives at Duke, one of which at least we're partners with UNC in the Odyssey registry. Um, so this is the FDA definition of real world data. It's very long and very dense, but basically, the idea is it's data relating to patient health status that are collected from a variety of sources. And I'm not going to read this to you. But basically, real world data is kind of the raw data, the facts and figures. And that's a little bit of a distinction between the evidence. So the evidence is that raw data that's been analyzed and interpreted. And so specifically, we're interested in obviously like the benefits and risks of different medical products or interventions that can hopefully improve health status. So I think we're all familiar with clinical trials, and clinical trials are very important. And so we've had a number of clinical trials in the field of kidney cancer in the last decade that have dramatically changed the field. But they're not the be all and end all. So some of their strong points are actually, you could think of as an Achilles heel. So I've listed some pros and cons here. And I'll give you some more specific example. But in general, clinical trials provide very high quality, internally consistent data. They can move the field, but they're answering a very specific clinical question. And so if you kind of turn that around a little bit, they do take a long time to read out. They take, years to plan and conduct. They take tens of millions of dollars sometime. And so there's a risk that they may no longer be timely at the time that they read out. Also, because they're so specific and so regimented, which is a strength, that's what makes them internally consistent, right? They're not generalizable sometimes because we know that patients who, and I'll show you some data about this, later on, but the patients who make it into clinical trials are not necessarily representative of kidney cancer patients in general. So let me give you one example. So this is a really busy slide that you don't need to read, but just to kind of walk you through this. This is showing you basically 6 different randomized phase 3 trials that were conducted in the field over the past decade or so. And up in the left right, you see kind of the eligibility criteria. These are the things, patients have to have or not have to be included in the trial. And then, the thing that's important in this slide, though, is that all were compared against sunitinib, Sutent, which is a pill that was a standard of care at the time. So why is that important? Well, it's important because the timeline of these randomized controlled trials was such that the very first trial here that read out that was compared against sunitinib or Sutent in April 2018, that drug combination, which I think was discussed this morning, was nivolumab and ipilimumab. That beat sunitinib head to head. So arguably, at that point, sunitinib was no longer a standard of care, right? So the field changed. But then over the next 3.5 years, these other trials read out, and I've highlighted them here in the boxes. So pembrolizumab axitinib, nivolumab cabozantinib, and pembrolizumab lenvatinib, and they all beat sunitinib again. But and that's important. And so I'm in no way minimizing phase 3 trials. These trials gave our patients a lot of different options and super important. But what the field really wanted to know at the point when sunitinib was beaten is, how do these regimens compare? And we really didn't have any evidence other than kind of indirect comparisons of trials. So one analogy that I like to think about clinical trials is the streetlight effect. So I think it's important, thinking about, how generalizable or not clinical trials are to real world populations. I think this analogy, and some of you are laughing because I think you've seen this before, but the streetlight effect is essentially a police officer sees a man searching for something under a streetlight. He goes and asks the man what he lost. The man says, "Oh, he lost his wallet." And they both look under the streetlight together. After a while of not finding the wallet, the police officer finally asks the man, "Are you sure you lost it here?" And the man says, "No, I lost it in the park, but this is where the light is." So I don't want to overdo this analogy, but I think clinical trials are important and they allow us to see what's under the streetlight, but there's a lot of the street that's not illuminated. So clinical trials can advance clinical care, but they're very narrowly focused is the basic idea. So, one of the strengths of real world evidence is it allows us to search away from the streetlight, if you will. I mentioned earlier, we've shown this, others have shown this, that real world patients are sicker than patients who make it into clinical trials. Another strength of the real world evidence is it can include more of the denominator. So, meaning the rest of the street that's not lit up by the streetlight. So, for example, I'll show you an example later. In one of our prospective observational studies, we were able to study active surveillance. So patients with metastatic kidney cancer who did not get treatment, who were observed. And this was important enough that it made it into the NCCN guidelines. It also can allow us to study different aspects of care which aren't typically studied in clinical trials. So with real world evidence, we can study, for example, physician decision making, and I'll show you a little bit about that later. Um, So, the spectrum of real world evidence studies, I'm not going to read you this, but just to kind of give you some examples. So, pragmatic clinical trials is one example. This has, to my knowledge, this hasn't been done in kidney cancer, but there is a large cooperative group study in lung cancer that looked at pragmatic clinical trial design. And what we've really focused on at Duke is prospective observational studies. So, I'll show you later. We've done observational study called MARC and then another one called Odyssey. There's also electronic medical record studies or health record sources. Flatiron Health does this, and then the IMDC I'll show you an example of later. And then, of course, things like administrative claims data. So focusing on that first, or sorry, I guess it was the third category. So retrospective studies. This is easy to do. You can look in the health record. It's common that our fellows, this is one of their first clinical research experiences, is to look in the health record and kind of try to answer a question that we couldn't otherwise answer. And so this is an important set of criteria for metastatic kidney cancer. Has anyone heard the term IMDC before? Few heads nodding, mainly the healthcare providers. But basically, what they did, and this was done, well over a decade and a half ago, is they looked at patients who were treated at 7 different centers in the U.S. and Canada, little over 600 patients, and they said, what factors can predict patients who do better or worse? And they came up with 6 factors. And so this overall survival curve, I'm not going to focus on the specifics of this, but this overall survival curve is essentially showing that you can separate patients out into different groups according to how long they live as predicted by these factors. And that's important when you design clinical trials because you want to understand the characteristics of your population. So this is one example of kind of real world evidence that's retrospective. But next, I'll transition into some different real world evidence, so prospective observational studies. So I mentioned active surveillance, and this is not a lecture about active surveillance, but the key kind of points to understand what I'm going to show you next is that in selected patients with kidney cancer, we don't have to treat them. Even if they have metastatic disease, we don't have to treat them initially. We may delay that treatment, and we can do that safely. And so we avoid the toxicity of systemic therapy. And importantly, we don't compromise their ability to live long and do well. And so I already mentioned the NCCN guidelines, but I think a key point that people, some healthcare providers that don't treat patients with kidney cancer don't really realize is that we do this active surveillance. If you talk to kidney cancer specialists, we do this. It's just that there's not a clear incentive to study it in the same way there is to do clinical trials of drugs. So going back to that streetlight analogy, so if you think about the kidney cancer patients in general, patients with metastatic kidney cancer, there's a population that gets systemic therapy. That's in the red here, the circle in the red. And there's a population that's maybe gets active surveillance. This is not to scale. This is just to kind of show you these concepts. But just to kind of realize, research studies only look at a subset. So they might look at the lighter red and the lighter blue, but we don't really know what's going on in the other colors. So real world data can allow us to kind of look at that. So these get a little into the weeds. But so let me just show you the data though. So this is just an example of a prospective observational study. So this is a clinical trial of active surveillance. And basically about 50 patients were studied. They were able to be surveilled, undergo active surveillance for about 15 months. So if If your other choice is getting, toxic systemic therapy, that could be good if, as long as it's not going to compromise your survival. Those patients lived on average about 2 years at the time, keeping in mind that this was around a decade ago, that seemed reasonable, and they were able to come up with some ways of predicting, who might do well from active surveillance. So we set out, and this is where the real world data comes in. We set out in our MARC study, which was a prospective observational study, to look at active surveillance. And so this is a kind of a complicated schema, but I'll walk you through it. So we took about 504 patients, of which 489 were eligible. And at entry, we essentially asked the physicians, and that's what that questionnaire is on the right. We said, are you going to treat this patient with systemic therapy, or are you going to observe them? And if they observe them, we asked them, why are you doing what you're doing, and what are you doing? And so about 28%, 143 patients underwent active surveillance, and that was our group that we were interested in studying. So this slide, again, is a little bit complicated. I don't want to get into the weeds of these figures, but we were interested in how long, compared to the trial, for example, how long could patients avoid getting treated with systemic therapy? So that's what's on the left. And then, did that impact patients' survival? So on the left, you see what we refer to as systemic therapy-free survival. This means how long they were able to continue to be observed without being treated. And that was 54 months, so pretty long. And then since we had another cohort that was treated with systemic therapy, so typically pills and IVs, we were able to show how those patients did in the blue on active surveillance versus the red were treated with systemic therapy. And I think you can see that the average survival was not reached, so very good in the patients that underwent active surveillance versus about 30 months in those who had immediate systemic therapy. So this, again, was cited in the NCCN guidelines that this is reasonable for certain patients to undergo active surveillance. So this shows you another piece of kind of prospective observational study evidence. It was our Odyssey study, and this is a collaboration with a number of institutions, including UNC and Duke. And so I'm showing you the same timeline I showed you a little bit earlier, but just showing you when the first patient was consented, so which was around April 2022. So right after, the key point of this is right after all of those drugs were approved based on the phase 3 clinical trials. So I'm not going to walk through this in a lot of detail, but basically we enrolled patients at these different sites. And I think a key aspect of this study is we wanted to get at evidence that they really didn't get at in clinical trials. So we made our primary endpoint around the patient experience. That's why we called it Odyssey. So I think someone mentioned Odyssey in the earlier patient experience, but we really wanted to understand the patient experience. And so we focused on patient-reported outcomes, no matter what treatment they got. These are the different centers, including many prominent centers around the country like Duke and UNC. The data is pretty complicated, so I'm not going to delve into this, but just to show you kind of the complexity of these types of studies, we had in the blue circle, we had data being entered by the sites. We had a central, through the Duke Clinical Research Institute, a central place where they administer the PRs. They would call patients, so that was more convenient for patients. We were able to get data from the electronic medical record and also from Medicare. So I'll just show you a few of our key findings. Again, I don't want to get too much into the weeds, but just to show you things that we're seeing that maybe were different from what they saw in clinical trials. So I'll focus on the 3 things here. So we were interested in really looking at kind of 4 of the regimens that are now used for metastatic kidney cancer in the first line and seeing, what those patients looked like. So a few of the key things we saw in the first upper red arrow is, whether patients had had a nephrectomy. In the clinical trials that I referenced earlier, that was around 80 to 90%. But here you can see it's much lower. It's around 50% or lower. So these patients are, obviously different in the real world than in those trials. All of those trials required clear cell histology. And we don't need to get into what that is, but these studies basically, these patients that were treated in our Odyssey registry, included patients who did not have clear cell histology. And a lot of those were things like unclassified, not otherwise specified, to patients that are typically excluded from clinical trials. And then the third thing I just want to highlight is our patients had a performance status, so kind of a functional status that was some of them had a lower functional status that would not have been included in trials. So up to, almost 20% of patients according to different regimens. Um, we also wanted to understand, as I mentioned earlier, as the primary endpoint, how patients feel and function. And so I'm not going to read this to you, but basically the key point is the higher the number, the better quality of life. And if you look kind of row, doublet row by doublet row, according to the color, you have the Odyssey patients and the pivotal clinical trial that would correspond to the same regimen. And in every case, the Odyssey patients had a lower quality of life. So again, just highlighting that those patients are different in the real world. Um, I think another interesting thing we saw was physician-selected reasons for these therapies. So this is a little complicated bar graph, but I'll kind of walk you through it. So if you look at the reasons along the x-axis, so we essentially, again, the physician and the patient kind of selected the therapy, and then we sent a questionnaire to the physician saying, why did you do this? And these were the reasons. So they were things like prolonged survival, complete response, delaying progression. And we allowed them to pick more than one, and we allowed them to weight them to 100%. And so I think, just to focus on kind of one interesting thing, if you look at the ipilimumab, nivolumab, bar. So that was that, and that's kind of farthest left, the purple bar. Physicians overwhelmingly pick prolonged survival, but with all the other regimens that are pill and IV combinations, they picked basically delaying progression. So that's one thing we found interesting. And then if you also juxtapose that against this, which is looking at the starting dose of the pill portion, patients who are treated with cabozantinib overwhelmingly got 100% started at the starting dose, whereas lenvatinib and axitinib were started at dose reduction. So, we'll see what that yields, but I think it was it's an interesting finding that physicians are starting a drug to delay progression, but yet are maybe reducing the dose right off the top. So we'll see that. We'll see how that looks. So we went through this, but just to conclude, and I want to leave time for Patty and time for any questions, but I think, real world evidence is becoming increasingly important, and it will only increase in the coming years with the pace of innovation. Clinical trials are very important, but they're limited, right? We talked about the timeliness, we talked about the generalizability. So they can't always give us what we need. So real world evidence could step in and fill that gap. There is now a precedent, and I didn't have time to talk about this, but there's a precedent in oncology for regulatory agencies like the FDA finding real world evidence credible. So there are two recent FDA approvals in the past few years based on real world evidence as distinct from clinical trials. There are challenges with real world evidence. You saw, I put that data sources slide up there just to show you kind of the complexity. We still have difficulties finding key parameters like performance status in real world evidence. So those will need to be solved. And then of course now with AI, so artificial intelligence, machine learning, natural language processing, some of those things may be solved, but they have to be validated. So I think, in general, the field is more accepting of real world evidence. When I came into the field, some older generation oncologists were very skeptical of real world evidence, and they would not accept anything but a randomized clinical trial is kind of the gold standard. But I think a lot of change is going to be coming in the next few years. So thank you for allowing me to give you my thoughts.